ધવલભાઈ આવી ગયા છે. ધવલભાઈ એટલે ભાવનગરમાં કે યુએસમાં? આમ તો સાન ફ્રાન્સિસ્કો સારું દેખાય છે.
ધવલભાઈનો ઇન્ટ્રો આવ્યો નથી ભાઈ, સીવી આવ્યો નથી. મોકલ્યો તમે?
Now we are having a YouTube live also. It started.
એટલે આમાં બે જણ એક્ઝોટિક છે. ધવલભાઈ છે સાન ફ્રાન્સિસ્કો છે અને સમીરભાઈ છે કંઈક બીચ પર છે.
અમિતભાઈ તો બીજો પર ફરતા જ હોય છે.
હા,
આ જીગનભાઈ પહેલી વાર ઘરમાં જોવા મળ્યા.
કામ એટલા માટે, બાકી તો હું ફરતો જ હોત.
ડાર્કમાં ફરતા હોય પાછા.
ડાર્કમાં ઝૂમ ઇન ડાર્ક.
સર મારું સીવી સન્ડે આવી ગયું છે. હું ફરી એક વખત મૂકું છું.
મૂકી આપો ને.
સાહેબ ફરી મોકલ્યું છે.
ઓકે. ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ બોસ.
સર મારો અવાજ આવે છે?
યસ.
એબ્સોલ્યુટલી લાઉડ એન્ડ ક્લિયર.
હેલો, અવાજ આવે છે મારો?
હા શ્રીધરભાઈ, પરફેક્ટ અવાજ આવે છે.
આ વેબિનાર છે ન્યુરોલોજી નો.
હેલો,
ગુડ ઇવનિંગ એવરીવન.
ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ. મજામાં ભાઈ?
બસ બસ એકદમ એકદમ.
કેમ છો રીતેશભાઈ?
તો મારી કરતા વધારે સિનિયર દેખાય છે હવે.
હા એ તો
मकानों को तोड़ दिया, महिलाओं से अभद्रता भोजन और चंदन की मौत ने देश को होने वाली उपकरण की राजनीति चरित्र दिखाया और आज
હેલો, ગુડ ઇવનિંગ. નીતિશ સર મારો અવાજ આવે છે?
હા શ્રીધરભાઈ આવે છે, પરફેક્ટ આવે છે.
ઓકે ઓકે સારું, ખબર નથી પડતી. થેન્ક યુ.
ના ના, લાઉડ એન્ડ ક્લિયર.
આવે છે એકદમ ફાઇન.
કેમ છો હિમાંશુભાઈ?
બસ ફાઇન ફાઇન.
હિમાંશુભાઈ ક્લિનિકમાં બેઠા લાગે છે. ગુડ ગુડ ગુડ.
ઘરે છોકરાઓ હેરાન કરે. ધવલભાઈ લઈ ગયા હોત તો સાથે સાન ફ્રાન્સિસ્કોમાં બેઠો હોત.
નીતિશભાઈ નેક્સ્ટ 3 મિનિટ્સમાં હવે સ્ટાર્ટ કરીએ.
સર પ્લીઝ.
Yeah.
અને કુંજશ્રી ઇઝ ઓલરેડી હિયર, એટલે સવાલ જ નથી.
રાઈટ.
I can start now if everyone is here.
અંલિકાબેન 2 મિનિટ પછી.
Okay.
યસ અંલિકાબેન, we can start now.
Good evening, everyone. Respected seniors, dear colleagues and friends. It's my pleasure to welcome you all today for the third episode of our Expert Connect series. This is a webinar series which is the Presidential Action Plan of AOP Gujarat. And today's episode is in association with the Neurology chapter of AOP Gujarat. So here we're going to discuss the common issues in pediatric neurology in office practice, for which we have a galaxy of esteemed speakers with us today and experts who are going to enlighten us on this topic. So before we start the session, I'd like to welcome the AOP Gujarat President, Dr. Jagdish Khamar sir, to give his welcome address. Khamar sir.
સાહેબ અનમ્યુટ થવું પડશે.
Good evening, friends. After the completion of Expert Connect 2 series adolescent and infectious diseases, now we are with third series of Expert Connect, that is Neurology in Pediatric. I welcome on behalf of AOP Gujarat, Professor Dr. P.M. Kunju of Medicine, Kerala University, and also former professor and head of the Pediatric Neurology Unit in Medical College, Trivandrum. I also welcome AOP Neurology team, that is Dr. Sanjeev Mehta, Dr. Siddharth Bhai, and Dr. Nitish Bhai from team RICN Ahmedabad. I also welcome Dr. Dhaval Bhai, Dr. Sridhar Bhai, Dr. Ritesh Bhai. Pediatric neurology now became a developing branch and very developing branch, considering there are many premature births and many test tube babies and many precious deliveries. So also I welcome all the colleagues and the faculties for the today's meeting. Over to you, Samir Bhai, to continuation for the program.
Thank you, sir. I would like to request the Secretary of AOP Gujarat, Dr. Samir Shah, to say a few words about the webinar.
Respected President Dr. Jagdish Khamar sir, all the today's expert faculties, moderator Dr. Nitish Vora sir, panelist Dr. Dhaval Solanki, Nishant Rathod, Himanshu Panchuria, Siddharth Joshi, and of course the experts across the country, including Dr. Anita Hegde, Dr. Sanjeev Mehta, and Ritesh Shah. My sincere welcome on behalf of the AOP Gujarat to each and every participant in today's webinar. It's really a great pleasure for us being a AOP Gujarat secretary. It's my pleasure to introduce this concept of expert connect with the help of the all the expert speciality available in the Gujarat. Many are hidden experts and few people are really well known across the country and the even abroad also. So our main aim and objective of today's this expert connect when we have started is to the nourish the new talent of the speciality under the roof of the such a known expert across the country that ultimately give us a good faculty inside the Gujarat. So our main aim and objective to the flourish the our new faculty with the help of the our old time tested faculty, and this is really a good that we are able to continue our third series of this. We had absolutely very successfully completed with the adolescent group, followed by the infectious disease chapter, and now we are again connected with the neurology chapter of the AOP Gujarat. And next, it coming in the line is the NNF, means neonatology chapter again in the next month. So my sincere thanks to the all the participants who is keeping continuously on eye with this expert connect and remaining connected with all of us. Sincerely thanks to the all the MOCs who are taking hard to connecting each and every faculty in timely that. And today's my MOC, Dr. Jigensa and Dr. Anjalika Mehta, thanks to taking the burden of today's things. Thanks again and continue the proceeding. Thank you.
Thank you very much, sir, for your kind words. Now it is my pleasure to welcome and introduce Professor Kunju sir. He is the chairperson of the National IAP chapter of Neurology, AOPN. He is the Dean Faculty of Medicine at Kerala University, a senior consultant of pediatric neurology at KIMS Trivandrum. He has been the former professor and head of pediatric neurology department of Medical College of Trivandrum. I welcome you, sir, to please speak a few words.
Thank you, Dr. Angelica. I am happy that I am joining the Association of Pediatric Neurology Gujarat, as well as the IAP Ahmedabad and Gujarat. I am happy that Dr. Siddharth Shah is the president of AOPN Gujarat, and I am happy Dr. Nidish, Dr. Jigen, the president, then Dr. Jagadish, Dr. Rajiv, Dr. Samir Shah, Nishanda, Dr. Anita, Dr. Sridhar, Dr. Dhawal, Dr. Himanshu, Dr. Nirmal, Dr. Ritesh Shah, all are welcome. I'm happy to be a part of this program, especially the expert connect. So that is a very, very catching caption. And of course, today we are having a case-based discussion. I must congratulate Dr. Siddharth Shah as well as Dr. Ritesh Shah and Dr. The president of AOPN Gujarat, Dr. Krunal, and Dr. Jigen Shah. All are very much into pediatric neurology. I am happy that your chapter is going on in a very nice manner. We all cherish the AOPN National Conference in Ahmedabad, where the hospitality was excellent and it was attended by more than 400 delegates, which was a very, very rare occurrence. Anyway, I am happy to wish all the success for today's Expert Connect program. Thank you.
Thank you very much, sir. I would like to acknowledge the presence of senior expert pediatric neurologist Dr. Anita Hegde, madam. She is a senior consultant for pediatric neurology at SRCC Mumbai and a very well-known academician. Welcome, ma'am. I would like to also acknowledge the presence of the chairperson of AOPN Gujarat chapter, Dr. Siddharth Shah, and the secretary of AOP Gujarat chapter Neurology, Dr. Ritesh Shah.
Thank you very
Welcome.
much.
Now, without much ado and wasting much of time, we'll directly proceed to our panel discussion. I'm sure we're going to have a great learning today. For that, I would like to now give the further proceedings to my co-host, Dr. Jigen Shah.
Thank you, Angelica, madam. Thank you, AOPG, for giving me a grand opportunity to handle and to perform as a MOC duty. Our panel, we are going to start our panel discussion. Moderator will be Dr. Nitish Vora. He is a well-known pediatric neurophysician working in Ahmedabad. Our experts are Dr. Anita ma'am, Dr. Angelica ma'am already introduced her. Dr. Sanjeev Mehta sir is also well-known pediatric neurophysician working the last more than 17 years in Ahmedabad. And Dr. Ritesh sir is a senior pediatric neurophysician working at Surat since last 15 years. Our panelists are Dr. Dhaval Solanki. He is from Bhavnagar and working since more than 12 years. Dr. Nishant Rathod is working as a pediatric neurophysician in Rajkot since more than 5 years. Dr. Himanshu Panchia currently working as a pediatric neurophysician in Surat, and Dr. Sridhar Joshi is the youngest and dynamic pediatric neurophysician of Vadodara. Warm welcome to all of you all, and I request Dr. Nitish Vora to start the proceedings.
Thank you very much, AOP Gujarat, Jagdish sir, Rishmi Khabar, Samir bhai, Anjalika ben, Jigen bhai for nice introduction. Special thanks to both the seniors, Prof. Kunju and Dr. Anita Hegde, who are our academic mentors throughout years and years. And we have learned a lot and we still keep learning from them. So thanks for their blessings. So we'll directly focus on today's session. And thanks to all the panelists and experts. So let's move on. So neurological disorders in pediatric OPD, what we see. So first few things are, it's a common problem, neurological disorders. And if you see all pediatric OPD patients, neurological complaints amounts for around 12 to 18% of all the patients. And of course, it has variable frequency, disease pattern is variable, and it has season as well, like everyone has. The extrasystemic complaints with neurological origin accounts for around another 15 to 20%. So it's a huge burden, and every child, means every OPD you will see 2, 3, 4 patients with some neurological problems. So what we commonly see, or we all will be seeing, will be seizures. That's fits, faints, funny turns, everything included beyond epilepsy. Developmental delay in various form, and as sir said, lots of preterm and birth-related things happening. Headache, syncope, vertigo, vomiting, that's again another common thing. Lots of behavioral problems nowadays with the screen time, autism, ADHD, etc. Learning difficulties, again a big burden. Weakness and pain, again that's something now. We are getting more and more patients of weakness. Nocturnal enuresis, lots of functional issues, parental anxiety, those things happening as well. And list goes on. There are so many things. But important thing is, as a neurologist, as a pediatrician, we need to keep our eyes focused. And we have, our eyes open, brain open, and then the brain knows. That's what says, I see what brain knows. So we'll discuss few cases on that. As we all know, history is very important, and we all must take a detailed thorough history from conception to current age, up to third degree relatives, family history, pedigree, details of original duration progress, detailed parental history, neutral adverse events, especially for feeding, etc. Each development lines should be taken in the detail, nutrition, immunization, past medical history, as we know, and of course, social and academic performance in school. Also, detailed thorough examination with the growth chart, general examination from head to toe, detailed neurological examination, dysphonology, and systemic examination. So without thorough history and examination, nothing starts. So that's very key. So I was starting with a headache when I put this picture. So I started a few weeks back. And when I was putting this picture, when someone said, who is this? And I said, is it Trump? So I think it's a headache for current financial era at the moment. So we'll start with the headache cases. So we'll summarize the history, and then our participants can give the history details. So headache is again very common in children, and average we can say 5 to 7% of the children will have some headache throughout their lifespan. So it's a big number. And onset can be very early. Previously, we thought it's like kind of teenagers will be explaining kind of headache, but now even 5 years will explain very nicely. So let's work on that. Such case one, 10-year girl, birth, past, and family history uneventful. Her development was normal. School, she's in fifth year primary school and doing good. She has a headache off and on from last 10 months. Lasts for few hours to whole day, variable frequency, more in evening hours, never in sleep, and in between she's normal. What she described is a bifrontal throbbing kind of headache. She does not like noise or light during this period. She feel tired and washed out during that period while she's in headache. Uh, one vomiting in the evening, and usually vomit relieves the headache, as well as either taking rest or medication will relieve the headache. So I will start with our panelists. Dr. Dhaval, means you got the history. What do you think? What's going on from the history?
Yeah, Dr. Nitish, from the history, we are dealing with the episodic headache, and that is also from means more cancer. Headache on and off since last November. So we are not dealing with illness, mesothelioma.
Yes.
We are dealing with under severe disorder, mesothelioma.
Dr. Dhaval, slightly louder.
Hello.
Slightly louder, yes.
Yeah. So, hello. Now I'm
Yes.
audible?
Yes, better now.
Okay, fine. So we are dealing with the headache on and off since last 10 months. Young girl, no underlying serious disorder. It is not disturbing her sleep, but she has a bifrontal throbbing headache that is very typical and does not tolerate the light and noise. Okay, and she feels the tired and vomiting relieves the headache. So very typical of childhood onset headache, and most likely we are dealing with the migraine.
Okay. So Dr. Nishant, so Dr. Dhaval thinks this is migraine. So can you elaborate more light on means why do you think migraine and what else supports your diagnosis clinically?
Yeah, so if you look at the history, the pattern of the headache is very well established. So typical migraine without aura is the diagnosis here.
Okay.
So depending on the pattern, we can diagnose. Here it is a throbbing pulsatile variety associated with photophobia, phonophobia, and nausea, vomiting. And typically the headache is relieved by the vomiting. So which is very typical of migraine. And here there is no aura, so it is a migraine without aura here.
Sure. So that's very helpful. So the different kind of migraines, but this is migraine without aura. Dr. Himanshu, clinically, our colleagues are happy. This is migraine without aura. Uh, how would you work up this child and what information you keep collecting?
Yeah, so it's a since our diagnosis is migraine, which is purely a clinical diagnosis, we do not require any fancy investigation. But thing is that we need to keep the headache diary, which is the most important thing from the parent, from the child if it is weak. And we can do regular blood checkup. We can do one fundus examination, whether there is a signs of any raised ICP is there. MRI is usually not indicated in this case. But in any headache, MRI is usually an imaging of choice if it is required.
Okay, so I think that was Sridhar to also suggest. But Dr. Sridhar means workup wise, what Dr. Himanshu said is a headache diary, both by patient and parents. Blood pressure at every visit, fundus examination we do, no routine test. But how about the in neuroimaging? So Dr. Sridhar, when would you do neuroimaging in child with a migraine? Or would you do it or not? And if you do, when would you do it? Dr. Sridhar.
So if the history is clear for migraine, I would not do a neuroimaging.
Ji.
But for any child with headache, what we would like to know is, are there any red flags? So if I have a red flag like early morning headache or child wakes up with headache or wakes up with headache and vomiting, diplopia, features of raised ICP like pulsatile tinnitus, or if the headache has a positional or provocative factors. So
Sure.
if I have the secondary signs or change in pattern, so we have seen patients of migraine who are obese and now have daily headaches. They have new onset pulsatile tinnitus, and then they turn out to be idiopathic intracranial hypertension. So
That's
if there
true.
is a change in pattern, if there are red flags, then we would require a neuroimaging. If there are no red flags and if there is no change in pattern, then neuroimaging will not be required. Just we can manage with
So if you're doing
lifestyle
the
measures.
neuroimaging, what will the your choice?
So if I'm doing neuroimaging, if I'm suspecting something like a IIH, then it would be MRI brain with MR venography to look for features of transverse sinus stenosis and other features of raised ICP.
Sure.
If I suspect a etiology where blood-brain barrier is broken, like in case of infection, a space-occupying lesion, or neuroinflammation or demyelinating pathology, where I expect the blood-brain barrier to be broken, then I would use MRI brain with contrast.
Perfect. That's
So
very
MR
helpful.
venography only if there are signs of no other signs and only we are suspecting a IIH.
Perfect. Very helpful, Dr. Sridhar. Thank you. So, can we, this is, I think, important question. From the, Dr. Sridhar, again to you. Can someone from the history specific headache pattern, you can diagnose headache or specific types?
Yes, we can. At least we can get a clue. That's what I
Okay.
feel. So, any child with headache, we should not forget that, okay, sinusitis is one of the main causes. So, if the pain is behind the forehead, and if there is sinus tenderness in the frontal sinus or the maxillary sinus, or if there is continuous postnasal drip, then I would think of sinusitis. Most common, what we get in pediatric population is migraine. In adults, migraine is usually unilateral, but in pediatrics is usually bifrontal and bitemporal. Sometimes they may also have posterior headache and they may also have neck pain. So some of these children may also have posterior headache and neck pain, which is there, which is throbbing, associated photophobia and phonophobia and relieved with vomiting more in evening time. All those are classical features we describe. If you have band-like constricting pattern in a child who is emotionally disturbed, who is having exams or stressors, then we can, or any family conflicts, then we can consider like a tension type headache. Cluster headache is very rare in children. I have seen only one case, but they usually have periorbital pain. And during the episode of headache, they have conjunctival suffusion and tearing. So that is classical, which is cluster headache, which comes under now terminology known as trigeminal autonomic cephalgias. So they have
Sure.
autonomic features with them. So
That's
this is how we
very
can
helpful. So
get diagnosis.
so basically it may not diagnose perfectly, but it gives a clue to use, and that's very helpful to work further. So we'll not go into theory, but let's move. So same girl, this is case continues. Same girl, she has started it as summer now. She started swimming lessons. She has a cough, couldn't fear from last 2 days. She has now a headache, which is all day round, occipital headache, which disturbs her sleep, occasional blurred vision and diplopia, and vomiting in the morning. So this is something has changed. So Dr. Himanshu, what's going on here? What's your likely diagnosis?
Yeah, so as Sridhar has mentioned, now the pattern has changed since last 2 days, associated with fever, occasional blurring vision, diplopia, vomiting. But some signs of raised ICP is there. So, and definitely child goes to swimming. So we need to rule out meningitis.
Sure, that's very helpful. Dr. Nishan, so our team, Dr. Nisha, Dr. Himanshu feels this is meningitis. So this girl has came to you. How would you work up this child?
First of all, I'll take a BP measurement, which is must in all cases of secondary headache. Then I'll do fundus examination, which is also must. And as our primary diagnosis seems to be meningitis with raised ICP signs, I would go for a neuroimaging, particularly MRI brain. And we are suspecting probably infective or inflammatory etiology. So we'll do contrast study also.
So that's very helpful. So apart from infective markers, definitely blood pressure, fundus, and MRI brain with contrast. So we can say this is either meningitis with raised ICP. So this is acute symptomatic headache or secondary headaches. So Dr. Dhaval, we are all talking about some red flags, red flags. In this history, what are the red flags?
Yeah, Dr. Nitish, red flag in this case, the changing the pattern of headache, what Siddhar says. Then the features of raised ICT like blurred vision, diplopia, early morning vomiting. So these are the red flag signs. Okay, it alerts the pediatrician to do the further investigations. And we are not dealing with the chronic or non-emerging migraine. So it is something urgent.
Interesting, urgent. So that's acute
That
symptomatic, and
is a red flag.
absolutely. So if any child wakes up with headache in the middle of night, or that's always something wrong. So you have to take this very seriously. So this is not the same child, but you can have, so like if you see that you can have papilloedema, um, uh, and other red flags we'll discuss. So if the secondary headaches, you may have SOL from any other reasons, infarcts or focal encephalitis, even the posterior fossa descent or tight posterior fossa, all those things. So if I summarize what my colleague says, where you want to act very rapidly is the red flags, where onset of headache is less than 5 years of age. So it may be still first episode of acute symptomatic headache, but less than 5 years, you definitely want to do it. Acute severe headache, which is new onset, uh, with other signs symptoms, where your subacute progressive headache. We'll discuss that in a few slides as well. But when it's subacute but progressive headache, you always want to do. Headache awakening sleeping child, that has to be looked at. Focal deficits, because that suggests some kind of pathology going on, so either hemiplegia, aphasia, visual field defects, persistent vomiting, even transient changes in neurology, seizures, meningism, periodema, they all change of headache pattern, and also change of headache with a posture or cuffing. That again suggests raised ICP or posterior fossa compromise. So all those things you will definitely think for something else is going on, and not routine headache, needs proper investigation, proper assessment by the neurologist, etc. So if we move on, this is third case, same girl. She has headache from last 1 week, all over the head as a band or squeezing, which is all day round, more at the school, better at home and in sleep, and she is very emotional at present. When we ask in detail what else is going on, and the penny drop. This is March month. I prepared the presentation last month, so it is March month. She had missed few weeks of school. Her schoolwork is pending. Exams are coming up, and she's not coping at school with all this going on. So, Dr. Nishant, from the history, what's going on? Uh, how you summarize?
So let's summarize the history. Duration is 1 week and it is diffuse all over the head. The pattern and the character is band like or squeezing. And it is a dull aching, prolonged headache and clear cut history of stressor. So this there is no any red flags. This seems to be a primary headache only.
Sure. And we all see this seasonal things like before exams, like January before prelims or March
Yeah.
before exams. This is a season, what we say about the. So, Dr. Himanshu, we summarize, but can you label what we are talking about?
Yes, it's definitely looks like tension type headache,
Tension, diabetic, stress, headache, absolutely.
stress headache, psychogenic, whatever we call it.
Psychogenic, yes. So better use tension or stress headache, because psychogenic people sometimes take it in a
Yeah.
negative way. So absolutely. So this is tension type or psychogenic, as we said. So these are the daily headaches, but no exaggerations. Constant band-like sensation, as discussed. It's usually low intensity. It does not disrupt activities. So child keeps complaining of headache, but everything, TV, work, running around, eating, drinking, nothing gets affected. In migraine, children feel very pale, tired, they don't want to do anything, lie down, exhausted. Here, it does not affect the activities. And there is some stress, some exam, anxiety, something going on. So, emotional factors. And there is some evidence of psychosocial factors, headache with chest pain or abdominal pain, etc. Poor response to therapy unless you understand what's going on. So these are difficult children. You need to get to the actual bottom of the issue, and then you can work well. So thanks for that. This was tension headache. Now things are getting more complicated. So far things were right. So I will go through slowly here. Everyone please focus. This is 13-year girl, different child, daily headache since last 1 year. Does not disrupt activity, which is bitemporal and around the head. It's usually mild, sometimes severe during menses, lasting for few hours. She has been photophobic, but no vomiting. She needs to sleep or take analgesics to relieve, and it's usually early morning. Sometimes constrictive pulsatile when severe. There is headache in the family. There is a family history of headaches that are going on. There is past years of infrequent headaches as well. There is also ongoing some school absenteeism, learning issues, and low self-esteem. So complex things were going on. So was reviewed. Her examination was normal, and MRI brain was normal because things were not clear. So MRI was done. So MRI was normal. So quite a few things going on, and this is usual things what comes to us, not straightforward migraine as a stamp label or something like that. So Sridhar, if we just tease up the history, what's going on? We are not looking for diagnosis, but few salient points from the history.
So here, if we see from history, we can say that there are no red flags at least.
Okay.
So we are dealing with now in primary headache, we have certain features which suggest migraine, like my headache associated with phonophobia, bitemporal headache, which is pulsatile with positive family history. So this all suggests migraine, but now it has become daily and it's not disrupting activity. There is history of school absences and learning issues and low self-esteem. So all this points towards psychogenic or attention type headache. So we have a overlap syndrome going on over here. So
Perfect.
what
So this
we
is
usually
khichdi.
call khichdi, so what we call like TTH migraine overlay or migraine TTH overlay or a transform migraine.
Sure.
These are the terminology. So,
Different terminology.
but the main thing which we pediatricians need to know is there are no red flags. Till the time there are
Yes.
no red flags, we are rest assured that it's a primary headache. And in primary headache, then we need to tease out what are the features for. If the features have both features of a migraine as well as TTH, we need to make a diagnosis of both, and both the factors need to be addressed in management.
Sure. So important thing is no red flags, and there are different things going on, and we need to appreciate those different things. Okay, so this is a few things are migraine without auras, as we said, bilateral, no visual or other aura, but worsened by menses, phonophobia, pulsatile, family history positive, helped by sleep. These are all migraine kind of thing. Tension type because it's continuous, mild constricting, does not disturb sleep, and also psychogenic or stress, other things going on like misses school, all those things. Dawal means we know this is transform migraine or other definitions as well. So how you deal with this child?
Yeah, I see the very big assessment library itself. It is essentially the chronic migraine and intermittent being the migraine exacerbation. So we need to take care of that intermittent exacerbation, mainly at the time of menses, when see child gets stressed. Okay, mainly adolescent and adolescent related issues, migraine gets exacerbated. Then in the background, there is a daily headache. This is due to tension type headache. So exam due to the peer due to the social factors, exam related stress, that is a psychosocial factor that also worsens the tension type headache. So we need to give the treatment for the acute exacerbation of migraine, and we need to take care of the psychosocial factor to relieve the tension type of headache. Here the drug overuse is a main issue because the parents also think there is a severe headache, daily headache, so they will give the daily and NSAIDs, and it is not recommended because it will worsen the things. Okay, so at the time of actual intermittent migraine exacerbation, the NSAID will not work.
And also
So
keep and then school absences keep increasing, and then the vicious cycle sets in.
Yeah, exactly. So
Our chief expert. Yes, Anita madam, these are difficult cases. How do you deal with these kind of children in your practice, ma'am? Some guidance to us.
So I think the most important thing is counseling to the parents. First, you have to tweak out between them which is the real and which is the not so real. And you have to identify the concern. You have to get the child on board with you. You have to get the parent on board with you. And I'll be honest, sometimes these are the most difficult cases to treat.
Well,
the regular migraines are much easier to treat than the intermittent as well as the psychosocial factors which get added on. So I think it's just counseling at this given moment, and explain that it's nothing to be worried about, nothing to be serious. See that the migraine treatment, the lifestyle changes, you're working on that as well. You've ruled out all the red flags. I think you just have to counsel them accordingly.
That's very useful, ma'am. So it's not it's easy said, but as you said, it's very difficult in teamwork and lots of counseling. Thank you very much. So we are moving on with the theme of headache only, but some other perspectives. So this is a 9-year boy, recurrent episodes of visual aura. So he describes a sudden colored wall, and he always says a red kind of I mean, so bump फूटता है ऐसा कि लाल कलर का गोल गोल घूमता है in front of the eyes, and it's followed by severe throbbing headache. It is diurnal, lasting for a few minutes, and no loss of consciousness. So he wanted to know more. So he had one focal seizure, and ED showed oxygen spikes. Nishan, miss, this is some unusual thing for general practice. So what do you think? What's going on? Can you describe? I mean, what do you feel?
Yeah. So from history, there is clear-cut aura followed by headache,
Okay.
but certain points are against migraine or a headache, primary headache, like
Okay.
it is lasting for a very short duration,
Okay.
and the event is recurring frequently, right?
Ji.
And with history of one focal seizure, and age is also localizing to occipital lobe. So I'm more inclined to call it a seizure than a primary headache or migraine.
Perfect. So it's still, I mean, it's presenting as a headache, but it's something different. That's very
Yes.
helpful. So, means Himanshu, means it's got some history, but how do you differentiate specific by type of epilepsy, like ocular epilepsy and migraine, from the history point of view?
So in both auras are different. In occipital lobe epilepsy, aura lasts usually for few seconds to few minutes, and in migraine, aura lasts for at least more than 5 minutes, can last up to half an hour. Usually, epilepsy depend on frequency. Usually more frequent than migraine attack, and aura usually moves in occipital lobe epilepsy from one side to other hemifield, while in migraine it's moves centripetally from center to periphery. In usually occipital lobe epilepsy, there are other signs of seizures are there, like loss of consciousness, some jerking, like that. And in migraine, there is no such kind of things. And in occipital lobe epilepsy, usually vomitings are rare, and in migraine, vomiting are common, and which also relieves the headache.
That's very helpful because I think we sometimes quite a few children with hypoglycemia missed and we don't know what's going on, or even the kind of late childhood kind of ocular epilepsies. We do see this kind of children. So that's Dr. Himanshu very helpful to differentiate from history ocular epilepsy with versus migraine with aura. And this is a few pictures from the Panetopoulos book. So aura, if you see occipital epilepsy and migraine, they have different aura. So what epilepsy is excessive electrical activity. So what you say is more excess electricity, creative thing, bright, colorful things. So when the children ask to draw what they saw, so they draw circles or different blobs, different hazy things, but usually colorful things, lots of colorful blobby things. And of course, EEG will show oxygen spikes, where migraine is a negative phenomena. So usually because of loss of blood supply, a constriction, etc. And people who have experienced migraine, it's a zigzag line kind of you feel, or from center to periphery, you see a kind of dark imaging going on. No blackout, but this kind of black or grayish things, it's more common with the migraine. So one is positive phenomena, it's epilepsy, negative phenomena is a migraine if it explains that way. So let's move on to some other interesting cases of headache. So you have an 8-year girl, which is a headache with a trance-like situation for few minutes. Trance means blank episodes for few minutes. She has abdominal pain, chest discomfort, some headaches that's off and on and daily for last 1 year. She's average in school and sometimes she looks frightened, but normal neurology. So things were going on, and this headache, because it's going on 1 year and people not sure what's going on. She has seen psychologists, some natak kariye, school mein average hai, let's do something. She's been given some psychology treatment, did not work. She has recurrent abdominal pain. So she went to so many other people, USG done, normal. Luckily, no appendectomy done. But it happens. People do get endoscopies and appendectomy and so many things done. Some chest pain, discomfort, not sure. She had a cardiac workup, again normal. Still things are going on. Sridhar, what this could be?
So here we can see that it's not a run-of-a-mill headache, which we are discussing in last few cases. Here we have few things. We have trance-like situation. So this history to come from parents is very important. And she looks frightened. So we have something which is known as behavioral arrest.
Okay.
We have abdominal pain. Okay, she is feeling frightened. She is missing school. And maybe because of this headache, she has become dull in his scholastics. Maybe we can get this history that was she like this before or not. Another thing is we need to ask the parent or the child, do you remember what happens during these episodes? If they remember, it's usually a headache which is primary, but if they don't remember, this 3 A's, the amnesia of the event, the absent look, and the abdominal pain, these points, they should make us think regarding temporal lobe epilepsy, usually arising from the medial temporal lobe. So these 3 A's are classical for medial temporal lobe epilepsy or abdominal epilepsy, as we would like to call
Sure.
in this
So
case.
basically,
So
this girl had further workup, and she had temporal spikes, and MRI did show left-sided median temporal sclerosis. So this is temporal lobe epilepsy. So temporal lobe epilepsy, usually what happens is you have that epigastric discomfort, some fearful sensation, uprising things. So people feel it's a kind of either psychiatric kind of things going on, or some reflux or chest pain and cardiac things. There's a genuine feeling of fearful and fright on fright. So this is usually abdominal epilepsy that usually people used to say, but that's temporal lobe epilepsy. And usually blank and some mouthing and autonomic dysfeatures can be there as well. Sometimes I'm not going detail, but abdominal migraine or cyclical vomiting, spasmodic, those things will be associated as well. I want to differentiate few things as going on. Is something on secondary headaches. What are secondary headaches? Because we are talking about primary. Secondaries are bad headaches. So you can have SOLs, tumors, hydrocephalus, abscess, raised ICP causing things, hematomas, all those things. Inflammation, infection, meningitis, encephalitis, IAH, BIS, these are all secondary headaches. These are the bad headaches where you need to have, means be careful. Primary headaches are usually migraine, which with aura, without aura, or migraine variants. Tension type, stress headaches, psychogenics, what we thought, and chronic headache. So most of headaches in children are primary. And if you're thinking for secondary, it's something bad and need to work up very rapidly. So, and of course, rarely cluster headaches. So if you, as a headache diary, if you just try to tease out important aspect about the headache, what's going on, what's the frequency, and how they behave. So if this is a baseline, so black is your baseline, so no headache. This is acute no onset headache. So it comes, has a peak, and a few days or few hours, it goes away. It's an acute new onset headache. If it's keep happening, it's acute recurrent headache. So where it child has in between is normal, baseline is 0, and then has an episode and again come back to normal, and in between normal. That's acute recurrent headache. This is a pattern. Other is subacute progressive. So it started somewhere, but it is not coming down, never touching baseline. It keeps going up slowly over weeks and months. It's get increasing. That is subacute progressive. And something where you have dull headache going on. So it's chronic headache. You not touch the baseline, but it's not increasing that much. But on specific aspects, specific areas with the stress, anxiety, school, tiredness, whatever, it gets bumped up for few hours, few days, and again back to their normal baseline. So I'm not saying zero baseline, but for that child, what's ongoing going on. So if you think this pattern and try to divide your headache, so acute or new onset is can be anything like we are talking about infections, meningitis, trauma, raised ICP, all those things. Of course, migraine starts somewhere and it will be first episodic headache as well, but rarely stroke. So all those things are new or new onset. When you acute recurrent headache is almost always migraine. When it's a chronic non-progressive, these are the bad headaches, chronic daily headaches, tension type headaches, all those things. But when it's progressive secondary like SOL, tumors, means raised ICP things. So in acute episodes and subacute progressive, you have to be very careful. Primary headaches, you're fine. So this is broadly summary. So I'm talking to the experts now. So we have got some idea about the headache. Um, so I'll start with Dr. Sanjeev Bhai. What is the effect of screen use and headache? Because we are seeing lots of people, children with their mobile and laptops and TVs, and how you relate it with the headache.
Yeah, there are many studies now are coming up because of a lot of issues about the screen exposure that includes television, computer, mobile, वगैरह. But still, it is in an infancy state. But there is definite evidence that significant screen time leads to headache, fatigue in the eyes. So they have recommended television exposure if continuously 3 hours or more. That definitely leads to headache, and mobile exposure more than 2 hours. So need to take break in between. So exposure should be around 2 hours in the mobile, and for television 3 hours. Still, it is early studies, but there are definite evidence now.
And I presume because of lots of then straining of the muscles and all those things will be also leading to the headache.
Yeah, definitely.
Dr. Ritesh, there is a sometimes people when there says headache, they always immediately tick box should be ENT and ophthalmology. Is that true, or are there specific reasons where they should be referred or when they should not be referred?
So actually, automatically they should not be referred. Like ENT point of view, it is actually acute sinusitis, which is usually related to headache in pediatrics. And acute sinusitis comes with all other signs like nose problems, fever, earache. So there are clear-cut other acute signs of acute illness. So in pediatrics, we rarely see chronic sinusitis presenting as chronic headache. So it is a usually acute sinusitis. Chronic is usually not common in pediatrics.
Sure.
Second thing, refractory error has to be checked in all child when they start school. There's a part of routine eye examination. You can refer the child for ophthalmologist for a routine refractory error checkup. But headache, usually they present as asthenopia and not actually headache. They have eye strain on reading if they have a severe refractory error. So it is not must, but it is an opportunity to send the child for refractory error checking. So you can send for that perspective, not for headache perspective.
That's true, because most of headaches are primary and your interest is endoscopy. That's for secondary headache. So absolutely right, Dr. Ritesh. Anita madam, means before coming to you, again, Ritesh and Sanjay bhai. So when do you think child should be referred to neurologist from headache point of view? One by one.
Yeah, as you all have discussed, all panelists have discussed about. So definitely, when there is even first headache is very severe, we should not think about the migraine because it is an episodic headache. So at first episode, we cannot know the etiology. But if it is severe headache, first headache, definitely recurring sleep disturbances, and frequent vomiting more in the morning, any sleepiness, behavioral changes. So these are the indicators where we should not consider as a primary headache. Most likely, it is a secondary headache. There, they should go for a better evaluation with experts, basically.
Sure. Dr. Ritesh, do you want to add?
So just one comment that everything almost discussed regarding headache. One thing which is missed, which I have seen over the last 15, 20 years is IIH. So idiopathic intracranial hypertension is usually, pediatricians are usually not regularly diagnosing, they are not even suspecting. So in every child of headache, just get an fundus done if you're not sure. And whenever the pattern is not fitting with primary headache and something is odd, because all other secondary headaches has a clinical signs like SOLs, meningitis, encephalitis. But this IIH is slowly cooking up, and many times patient present to us with like literally vision loss of vision. So it is like one thing which is missed by routine clinicians is IIH, which I have seen in my practice a lot of times.
Absolutely.
So it is the only advice that get an fundus done in all headaches. Otherwise, everything is discussed.
So primary headache, again, no fundus, but any headache which is not, you're not sure, they get the fundus done. Absolutely. Another madam, coming to you. So lots of headache discussion, but your pulse of wisdom.
So there are a few things that I've realized. One is the family history of migraine is an important factor, given that 50% of the world has migraine. That's a good The second clue that I think is the history of motion sickness. If you take a history of motion sickness, invariably those with migraine will have either a motion sickness as a child or they still have motion sickness. So that's a little clue sometimes to give you a feel that you might be looking at a migraine or a migraine there. A blood pressure is something that you can never afford to miss. So I think that is an absolute must. And if you have it out, you wait, keep them outside, and you repeat it again, particularly if you have an occipital headache.
Yes.
And the one time I missed a diabetes. I missed a chronic headache which was coming and going due to diabetes, as a result of which I always do a random and a fasting RBS now onwards with any child who comes with a headache. It's just become part of my RBS. It was only one patient.
G.
You learn from each of them.
Absolutely.
But I think you gave an amazing array of headaches with all the associated complications and the different manifestations. Think simple first. I agree, Oftal and ENT are usually not needed. Eye strain is very different from headache. Pain above the eyes after evening times, watching too much TV, studying too late, poor lighting, all that. But other than that, I think you've covered it all.
Now that's very useful. So all those key points what ma'am says, blood pressure, proper history, even fundoscopy, and sugar as well. So if I summarize about the headache, we are still continuing. So common problem is headache is 5 to 7% with children. In older children, headache with or are more common, and younger children, CNS symptoms are more common. Now with the stress, exam, school, lots of parental pressure and peer pressure and screen time, that's all causing more headaches. Good thing is most of headaches are primary. So more than 95% of headache what we see are primary. So there's a relatively good headaches. And most primary migraine. So these are again good things. Of course, we are seeing lots of psychology, stress things going on as we discuss. But headache diary, blood pressure, and fundus are essential. Never forget that. And how to manage, we can discuss afterwards. So this was something on a headache. Now there's a 12-year girl. We are talking about the collapse. So she collapsed, and collapse is very common. Comes to OPD to anyone. So this 12-year girl brought with a history of collapse during school prayer when she had a sudden fall and unresponsive for 2 minutes. School teacher did a primary can call the parents. Child was sitting normally when parents visited the school. School already asked parents to undergo evaluation of the child. She was a healthy girl otherwise with normal birth and development. Dr. Himanshu, what would you like to know more? So this is available to you.
Okay, I would like to know what was the season, like what was the environment, whether child has taken breakfast or not, whether child was having any other illness, birth development is already mentioned normal. But after collapsing, does child have this stiffening, jerking?
Okay, perfect. So
Yeah.
this is information for you. So this is her background has been normal, parental, past, family, everything is normal. She had a fast on that day and had not taken anything in the morning. What she felt means, and it's very important that sometimes parents give the history, but we are so confident. Young children, starting from 3, 4, 5 years onwards, they can give a very good history. So always take the history from patient itself. Himself or herself as well. So what she said, she felt dizzy, curtain like coming things coming down. She felt uneasy, blackout, and she fell, but she can't remember anything afterwards. Also, the eyewitness account is very essential as you requested. She looked pale from according to teacher's perspective. She had perspiration and she was back to normal within a minute. So quick recovery. And her blood pressure was normal. So Dhavalbhai means we now know more information. So what are the causes of sudden collapse which comes to OPD? Sudden collapse.
Yeah, sudden collapse, mainly the syncope. That is the first and foremost thing what we are seeing in this age group, around 10 to 12 year of age, male and female. It is common in both gender. Second differential, especially in a girl child, the mitral valve prolapse. You can think about the mitral valve prolapse. And if there is a family history of sudden death, you need to check out the long QT interval syndrome. So long
Sure.
QT syndrome. So you need to check out the QT syndrome. Second thing, the cardiac thing. So sometimes the aortic stenosis is also presented to us with the sudden collapse. Okay. Then in the neurocardiogenic syncope, the postural syncope and cardiogenic syncope, they are the sub differential of the
So
syncope
that
itself.
so there are different types of syncope, right? But also means as we are discussing, like hypoglycemia, periods, all those things will cause collapse, and we have to be very careful what's going on. And mainly, as you said, syncope. So Nishant, Dr. Nishant, I mean, we all we're saying about syncope, syncope. What is syncope?
So if you look at the definition theoretical, it's a transient loss of consciousness as well as postural tone,
Okay,
and that is because of global hypoperfusion, and that the recovery is always complete and spontaneous in syncope.
sure.
So these 3 points are important. And in
So
pre-syncope, there is a feeling that I'm going to pass out, but one may remain conscious, but there is always a loss of postural tone for some time.
So important three things, as you said, is partial or loss of consciousness, postural tone loss, and near complete recovery. That's very essential. And sometimes the feeling what's going, I mean, it's likely to happen. That's a pre-syncope. And as I think double base means, or if I go to say it, so I think Himanshu said. So you can have specific features like you have nausea, epigastric discomfort, sometimes hyperventilation, dizziness, lightheadedness, coldness, epigastric, all those things. The important thing is, like, sometimes people feel that syncope means always floppy and fall, but it's not always so. You can have child who can be stiff, floppy, or even small jerks as well, focal or generalized jerk as well for few seconds, but this is short lasting. Even people may have involuntary passage of urine or biting of tongue, so those things will not differentiate as an epileptic seizure, but still those things can happen with the syncope as well. Okay. Himanshu bhai, Dr. Himanshu bhai, what investigation would you do here? Means, do you think this is a syncope?
First, I would like to do one ECG, 12 lead
Okay.
ECG with rhythm lead to see QT interval, any arrhythmia is going on.
Absolutely, because we are seeing lots of, it's athletes and stars, and they're falling on, they're in the gym or on the playground and suddenly collapse. So this is 12 lead ECG with genuine patient, and you can see there's a prolonged QT here. So this is a prolonged QT syndrome, and these are children. They're suddenly going to the ventricular tachycardia and collapse. So never, I mean, it's always do. Of course, blood pressure examination, all those things. Blood pressure in different position. We may need tilt test, all those things. But 12 lead ECG, as Dr. Himanshu said, with the rhythm strip, is very essential, and count the QTC. Okay. Sridhar, so when you get the child with a syncope, there are so straightforward children, but there are children whom you want to refer for cardiac workup. Which are those children?
So again, like we discussed in headache, we have to look for red flags. So if I have a child with recurrent syncope 3 to 4 times in last 1 month, or if I have a child with chest pain preceding syncope, or if the child has positive history of sudden cardiac deaths. Nowadays, we have seen lots of reels where people are dancing and they're just falling down. They're
That's true.
nothing but arrhythmia because of long QTC. Another feature which usually we need to ask with long QTC is any family history of hearing loss, because we can have Charvel-Lange-Nielsen syndrome which can be associated with hearing loss. So a history of hearing loss in family, history of sudden cardiac death, chest pain, recurrent syncope, syncope while lying down. These are a few red flags. On any cardiac abnormal examination like murmurs or mitral valve prolapse, we can get clicks and all those
Sure.
things. If we get, then we can do. And if we have a postural hypotension, so in any child with syncope, we need to do a blood pressure in sitting position and with 3 minutes standing. And if we have a drop, then also we need to do a cardiac or autonomic workup for this child.
Perfect. No, very helpful, Dr. Sridhar. So now we realize, Dr. Dhaval, this was straightforward syncope. It was because of fasting. There was no red flags, and a child was absolutely fine, healthy, and was going to discharge home. What advice would you give to the family?
Yeah, because it is very frightening condition for the child as well as for the parents and as well as for the teacher. We need to reassure. The reassurance is must. It is not life-threatening condition. There is lifestyle modification is certainly required. So avoid the fasting, do proper hydration, always take enough amount of water, take salt containing sweets and something with you. And if during the prayer, if child has to be stand for a long time, then he need to move the calf muscles, because calf is our peripheral heart. So there is a circulation. So that is advice I'm giving in my own person. Okay, moves your leg when you are standing for a long time, and we can give him the isometric exercise under guidance of the parents. We need to teach, you have to stand for the 10 minutes in the standing position. If you are feeling a pre-syncope, you just sit down. So that's why this exercise will build up the calf muscles circulations patterns, and it is a less chance of postural hypertensions and fall. Okay.
That's very has to, and of course, do not start any unnecessary drugs or
Yes,
XYZ
the drug
drugs.
has no role in syncope.
Absolutely. Thank you very much. With the permission of the our MOCs, can I continue for next 5-10 minutes?
Yeah. We can
Please.
continue.
Thank you.
Interested topic.
Thank you. So this is a very nice quote everyone can read. Like what we're thinking, basics, why something doesn't work, because we forget the basics. Okay, this is about the acute lower limb weakness. We'll take one or two important clues here, and we'll take panel as well as help for the experts as well. So this is a 4-year boy, previously well, healthy, normal neurodevelopment, no family history to note, and presents with acute pain and weakness of both the lower limbs and walking difficulty over last 2 days. So, Dr. Nishant, this is a history. What information you want and what things are going in your mind?
Okay, so there is a acute history of pain as well as weakness. So I'll need a detailed history of origin, duration, and progress first.
Okay.
Yeah. So okay,
So
there
they
is a
say there is
history of,
no history of trauma. There's a
yeah.
cough cold for 2 weeks, and acute onset this from last 2 days with the problem in walking. There was a limp, and then it progressed with both the feet, and now slowly ascending weakness. Now child has difficulty in walking, and sit to stand is also difficult. Of course,
Yes.
child can sit and raise the hands, and no problem passing urine, stool, or coughing, means or swallowing. So these are the information I will to you.
Yeah.
So
So
what comes to your mind? What's going on?
in general, if we have a pain and weakness, I'll think of myositis or any traumatic limping, and then we'll think about serious causes like GBS or transverse myelitis and all. So with all these symptoms, it, it is pretty obvious that it is a GBS.
So GBS definitely possibility, but there are so many other DDs as you said.
Yes.
We need
Yes.
to think of that. That's very essential. So, Dr. Himanshu, we think it's a GBS here or acute facial paralysis. That's a proper word I will use. Um, and why you think your diagnosis of GBS is here? What clues are here?
Because there is a preceding history of viral infection is there 2 weeks back. Acute onset, ascending flaccid paralysis is there associated with pain. So all these are fitting in GBS.
Sure. So it's clues towards the GBS. Dr. Sridhar, how would you confirm this diagnosis? How would you investigate children?
So in every child with acute flaccid paralysis, we need to get a basic hemogram. Electrolytes, hypokalemia should not be missed because GBS is a painful condition. Pain can cause secretion of ADH, which can lead to hyponatremia. So electrolytes are must. CPK is required because one of the differential is a viral myositis, CRP, and to confirm which variant of GBS, whether it's axonal or demyelinating, we'll need nerve conduction study with F waves because in the initial first week of illness, nerve conduction study may be normal, but the F wave latency may be prolonged. But
Sure.
here, because it's an onset to nadir within 2 days, looks more like an axonal variant. So yeah, nerve
Common
conduction
variety.
study will be required. Yeah.
Absolutely. Dr. Dawal, so we think this is GBS, axonal variety, so Aman variety. How would you treat this child?
Yeah, so mostly we are dealing with, as Sridhar says, it may be axonal and it is very serious condition. It's a serious subtype of GBS. We need to hospitalize this child in the PICU and ABC. We need to monitor the airway breathing circulation. We need to monitor the autonomic dysfunction as well. And right way we investigate, as Dr. Sridhar discussed, we need to rule out certain things and we do the NCV and MRI brain if required in emergency, and we need to give the IVIG. IVIG is a drug of choice, 400 milligram per kg per day for 5 days or 2 gram per kg per total dose. Second option, if available, the plasmapheresis. Now, the certain center having a plasmapheresis. Down the line, the 4 week, the IVIG versus plasmapheresis result are same. So after a 4 week, if you see the cohort of the child, those given the IVIG and those who are taking treatment with plasmapheresis, the result is almost same.
Sure,
And then comes the supportive care.
Yes, of course, supportive care is very essential. So that's very essential. And thank you. I think I'm going to take some help of the experts here. I don't know, means Anita ma'am, what you get in Bombay, but here we get lots of history. Either missed GBS or some other diagnosis were there. So both in big cities like Ahmedabad or periphery small centers, sometimes doctors presume this is GBS as a clinical diagnosis. They get NC done by someone and they start IVIG. Then that's a I can't say standard practice, but this does happen regularly. So my question to you is, what is the role of neurologists in diagnosis and management of AFP? Anita ma'am.
I'll be honest, an EMG NCV in the acute phase may very often be negative. So chasing the EMG NCV is not going to give you the diagnosis. If you've got the clinical picture, if you've got an ascending paralysis, if you have the pain, which usually is a feature of the GBS, today you could think of an MRI with contrast spinal just to see if you've got the radicals are enhancing, which is over there. But if you've got the clinical picture and the child is deteriorating, I would not chase the MG-NCV. I would start the IVIG. I do agree the plasmapheresis versus IVIG. If you have the center, I think plasmapheresis has good results. After IVIG to do plasmapheresis is difficult. So if you have the ability, I think an older child, bigger weight, very expensive to give IVIG, I would have thought plasmapheresis. But otherwise, I would not chase, and then I can do the EMG NCV after 2 or 3 days. I can do the CSF if I want to convince myself. I can do the MRI if I want to convince myself. But the clinical picture is the most important.
That is very helpful, ma'am. Dr. Sanjeev bhai, what's the role of NCV in managing GBS? So diagnosis and managing both. Role of NCV.
Yeah, sometimes there is a dilemma in clinical presentation, like some asymmetry, some significant sensory changes, very early bladder bowel involvement. So we need to think about the other differences of AFP, like even transverse myelitis. Then definitely sometimes it will be better to confirm with NCV. As Dr. Ananta ma'am told, initially it will be negative, so we will not do immediately, but better to confirm at some stage for further management. And if there is a relapse is not responding, so we need to plan. If we are not missing the other diagnosis, so better to confirm. And in future, if there is a relapse, we'll know. Aman variant, previously we used to say prognostically is worse than AIDP. So even that can be only confirmed by NCV. So there is definite role, but it is not urgency to do on day one, but definitely better to confirm at second or third or fourth day of illness, basically.
Because as we are learning, means quite a few people are running behind NCV to say absent F base means GBS, but there's a huge role of NCV by experts in diagnosis as well as prognostication. I mean, it's not day 1, day 2, but day 3, 4, 5 onwards. Because as you said, Amman variety is different prognosis, EIDP is different variety outcome, it's relapse, it's all those things. Dr. Ritesh bhai, what's the role of neurologist specifically for GBS? Dr. Ritesh?
So basically everything is discussed, but like GBS is not a cakewalk. Like once you diagnose GBS, it is not easy. So you have a lot of complications. You need to predict those complications, like autonomic disturbances, respiratory failure, type 2 respiratory failures, hypertension, press. So a lot of things are there with GBS. So the people who are regularly managing it, it is very important to manage it in team with ICU specialists as well as neurologists together, so we can give the best results. And the role of neurologist specifically comes to differentiate. Like initial days, there is a confusion between sometimes myelitis and GBS, sometimes myositis and GBS, sometimes some acute porphyria and GBS, sometimes even MOG ADM presenting as acute flaccid paralysis. So there are few differentials to it. So all acute flaccid paralysis, hypotonia, hyporeflexia is equal to GBS. So all this teasing out the diagnosis between these 3-4 differentials is the role of the neurologist. And the next 1 week is very crucial for monitoring point of view, where also we need to very vigilant regarding autonomic disturbance and progressive respiratory failure and all these things.
Thank you very much, Dr. Ritesh. Sanjeev bhai, to you, means have you seen children dying of GBS not because of failure, respiratory failure, but
yes, Sanjeev bhai, so yesterday only I have seen one patient dying of GBS. Yesterday only.
Right.
So it was the second day of GBS, third day of GBS, admitted somewhere in some nursing home, and he just called me and said, "Sir, patient you have seen in the morning diagnosed with GBS. He came to my clinic. We had just admitted him, and he just collapsed, and we could not revive the child." Child expired. It is some autonomic disturbance or some cardiac arrhythmia which happened with GBS, Takotsubo cardiomyopathy or something like that. He is not sure. I am also not sure what happened. But we just lost one child yesterday only. Third day of illness, GBS expired. So it is not so simple.
Yeah, as the Ritesh told, definitely it can be fatal. Definitely because of not timely managed respiratory paralysis. Sudden death in GBS, arrhythmia, significant hypertension, definitely.
So autonomic dysfunction
to be autonomic, like even significant malignant hypertension, they can occur, which can lead to press also. So autonomic dysfunction are more common with hyperacute or those type of patients, basically.
Sure, Sanjay. So it's not just for breathing point of view in admission PICU, but you need proper assessment because there's lots of autonomic dysfunction and kids do die of this. Anita madam, your pulse of wisdom on GBS.
Pulse of wisdom on GBS. Few things that GBS, we all know IVIG is the drug of choice. The earlier we give it, the better. Many of them have associated severe pain, which is due to the radiculopathy. A short course of prednisolone or steroids for a few days does wonders in relieving the pain. So usually it's just a week's course that you might give, which will relieve the pain so that the child feels better and more comfortable. Monitor the sodium, monitor the bladder bowel, monitor the BP very rigidly. There is no role for second dose of IVIG as per the latest literature. You do not keep, if he's not improving as rapidly as you want him to, do not keep giving more and more IVIG. I think that would basically be start rehab as soon as the pain has settled. Don't do it when the pain is there.
That's true. It's very helpful, very helpful. So this is about GBS, and our chairs will be finishing with last one small case. So it's about painful gait, and I must say this is a case I like because it was fun in diagnosis. So this is a 4-year male, only child of healthy unrelated parents, normal birth and parental period, normal early development, fussy eater, has difficulty in walking from last 10 days. On exam is not keen for weight bearing, reluctant to stand or walk, and much comfortable in sitting position, DTR +2, because always we think of GBS absent reflexes. So these are things he presented with. He has seen so many people in last 5 to 7 days because means wealthy parents and pain and lots of MRIs, repeat MRI in NCVs and EMGs, and everything was negative. So I will not go to the discussion, but basically this turned out to be scurvy. It was fussy eater, it only pizza and pasta and noodles. And so means we thought scurvy is means poor people previous era, but now it still happens. This is a malnutrition of modern era. So this was my last Vinjay. I hand over to our MOCs. We have more cases, but we'll not discuss. We can discuss further at some stage. So Dr. Anjalika and Dr. Jigen Bhai, back to you.
Thank you very much. There's really interesting cases. It was fun listening to them and gave us a lot of insights for our office practice. I would like to thank all the esteemed speakers, Dr. Hegde Madam, the experts for today, Dr. Ritesh Rai and Dr. Sanjeev Mehta, all the panelists and the moderator, Dr. Nitish Bhai. You did a wonderful job today. Thanks to everyone. Dr. Jigen Shah.
Thank you all the panelists and all moderators, particularly Dr. Nitish Bhai and all the experts for wonderful experience and great learning experience about various type of headache, syncope, migraine, and lastly GBS. I have only one question: is there any treatment of prolonged QT syndrome if we diagnose on ECG, or it's a cardiologist view? Only 1 minute. Can anyone?
Nilesh, you were saying something.
Yeah, beta blocker is recommended for prolonged QTC.
Sorry?
Sanjeev, repeat.
Beta blockers are recommended for prolonged QTC and probably lifelong.
Okay. Beta blockers and in some cases with recurrent SIMCO, implantable cardiac defibrillators are also needed, ICDs. So yeah, that is in the purview of cardiologists, but I think neurologists do diagnose at least once in a year. One long QTC will come to us.
No, absolutely, they do come. Absolutely, more frequently.
Thank you so much.
Thank you very much. I must say thanks to all of my colleagues who are sitting there. And also AOPN Gujarat. So thanks to AP Gujarat who supported us to develop AOP Neurology branch, and our purpose was pure academics, which we did from last 2.5 years. And we are now more and more people joining with AOP Neurology Gujarat. So welcome to AOP Neurology Gujarat. I think I can request Siddharth and Ritesh, who are now president. So we started 2 years back, but now Siddharth and Ritesh are there to take the things further. So Siddharth, Ritesh, any comments?
Nothing specific. I just invite everybody to Surat. We have one CM in June by Academy of Pediatric Neurology Gujarat along with Surat Pediatric Association. So that's the only upcoming event.
Perfect. Most we'll be there. Thank you very much. Back to Miss.
Last few words from Dr. Samir Sir.
So it's a really excellent, such a mind-blowing and less headache-forming presentation from all of you. And it's a sincere thanks to the AOP Gujarat Neurology chapter and the Central Neurology chapter of the Central IAP for giving such a insightful presentation on the such a difficult case what we really encounter in day-to-day real pediatric OPD. And we usually try to avoid to attend this type of the patient in our regular OPD and most probably trying to send to the expert. But it's a really a time to come that what and when to refer, because this is our main aim and objective of this expert connect, because each and everything is not practically possible to send to the experts opinion, but when and right timely the referring will really help and sometimes save the life of a child also. So sincere thanks to all the expert panelists for giving their insightful presentation today. My sincere thanks to all the MOC and all the delegate who is still remain present throughout our presentation. Thank you.
Thank you, sir.
So we can conclude today's session.
Sir. Again, thanks Anita madam. Thanks Kunju sir.
Thank you.
Thank you.